Today we are exploring basics of wound healing. We will look at the overview, then go into detail about hemostasis, inflammation, proliferation, and remodeling. Then we'll learn ways to close a wound, classification, ethology, factors, some abnormal scars, proper wound management, and tetanus management. Subscribe to watch Part 2.
When adult skin is injured, it heals through 4 overlapping stages. The process begins at time 0. First, hemostasis occurs immediately to stop the bleeding. Then, inflammation follows. This spans the first 3 days. Next is proliferation. This phase builds new tissue over the first month. Finally, remodeling takes over. This final stage can last for over a year. Ultimately, adult wound healing universally results in fibrosis. You probably know this simply as a scar. So, immediately after an injury, the bleeding absolutely must stop. This process is called hemostasis. It happens through 2 simultaneous pathways. First, we have the cellular response. Blood vessels constrict, platelets clump together to form a plug. These platelets then release growth factors. You will see things like TGF-beta and VEGF. Think of these as chemical messengers. They are calling out for the body to start repairing. Second, there is the chemical response. This is known as the coagulation cascade. It generates an important enzyme called thrombin. Thrombin then converts fibrinogen into a strong fibrin mesh. This mesh acts just like biological glue. It stabilizes that platelet plug so the healing can begin.
As soon as the bleeding stops, inflammation begins. This is the body's natural defense mechanism. In the first 2 days, white blood cells called neutrophils rush into the area. They act very quickly to destroy any bacteria. Then, by day 3, larger cells called macrophages take over. They act as phagocytes. You can picture them as a microscopic cleanup crew. They clear away all the cellular debris. Crucially, they also release cytokines. These cytokines trigger the very next phase of healing. Healing then shifts into the proliferation phase. Here, cells called fibroblasts take center stage. These cells drive the production of brand new collagen. They also drive re-epithelialization. That is a highly technical word, but it simply means the growth of new outer skin layers. At the same time, special cells called myofibroblasts act like tiny muscles. They literally pull the edges of the wound together. Then, over the following months, the wound remodels. The initial weak collagen is systematically replaced by strong type 1 collagen. The tissue slowly gains strength. Eventually, it reaches about 80% of its original integrity. Now, while skin forms scars, other specialized tissues have their own unique ways of healing. Bone, for instance, can heal indirectly by forming a hard callus. Or if a surgeon fixes it firmly together, it heals directly without a callus at all. Nerves heal entirely differently. A severed nerve actually drops away its damaged ends. This is a process called Wallerian degeneration. Then, special cells create tiny tunnels. These tunnels carefully guide the new nerve fibers back together. Tendons also require very specific care. They heal through surrounding blood flow and fluid. In a clinical setting, moving tendons early is absolutely crucial. It prevents them from sticking to the surrounding tissues. Close a wound. We categorize this into 3 primary strategies. These are primary intention, secondary intention, and tertiary intention. Primary intention is always the ideal surgical aim. Doctors use sutures or staples to directly pull the wound edges together. We call this approximation. It leaves minimal scarring. Secondary intention is quite different. Here, the wound is purposefully left open. It heals slowly from the bottom up through granulation. Because of this, it causes more inflammation and a much more noticeable scar. Finally, tertiary intention is a careful hybrid of the 2. A highly contaminated wound is left open first. This allows time to clear any infection. Then, several days later, it is surgically closed. To make these closure decisions safely, wounds are evaluated on a spectrum of severity. We use the CDC classification system. A Class 1 clean wound
has no active inflammation. It strictly avoids the respiratory or digestive tracts. A Class 2 clean contaminated wound does enter those internal tracts. However, it does so under highly controlled surgical conditions. A Class 3 contaminated wound is usually an accidental injury. It might also involve a major break in sterile technique during surgery. At the most severe end is a Class 4 dirty wound. This is typically an old trauma. It usually contains dead tissue or an active, dangerous infection.
But doctors must look beyond just the level of contamination. They also evaluate the exact cause or etiology of the trauma. Was it a crush injury or perhaps an animal bite? They also measure the precise penetration depth. They look all the way from the surface skin down to the underlying muscle. Finally, they assess the structural complexity. A simple cut is relatively easy to close. However, a complex wound with missing soft tissue or organ damage requires profound surgical planning. Even with perfect classification and planning, healing can be easily derailed. These disruptions happen at two different levels. First, there are local factors. These exist right at the site of the injury. A lack of oxygen, a local infection, or physical tightness in the skin will physically stall the repair process. Then, there are systemic factors. These involve the patient's entire body. Advanced age naturally slows down the cellular response. Malnutrition deprives the body of essential building blocks. Smoking chokes off vital blood supply to the area. And chronic conditions, like diabetes, can severely impair the natural healing timeline. When these disruptions happen, inflammation lasts much too long. This fundamentally alters the remodeling phase and throws off the delicate balance of collagen production. The result is pathological scarring. Essentially, the body overbuilds the tissue. This abnormal healing usually manifests in one of two ways. It creates either a hypertrophic scar or a keloid scar. While both of these are abnormal, they behave very differently. A hypertrophic scar respects boundaries. It stays completely within the original edges of the wound, and over time it may actually naturally flatten and regress. A keloid scar, on the other hand, does not respect these boundaries. It aggressively extends beyond the original injury. It forms a raised mass, and it will not fade naturally. Genetics and darker skin pigmentation are strong risk factors for this aggressive type of scarring. To prevent these pathological outcomes, clinicians work to actively engineer an optimal environment. They deliberately remove biological roadblocks. For example, dead tissue and debris cause prolonged inflammation. The solution is careful physical removal. A lack of blood flow, known as ischemia, causes cellular starvation. The clinical solution is ensuring active circulation and hydration. Tight skin prevents cells from multiplying properly, so the solution is closing the wound gently, ensuring there is absolutely no tension. This kind of clinical engineering requires a strict, continuous framework. Every clinician follows a reliable four-step path. First, they prepare the patient and the wound. It begins with proper pain relief and a thorough washing of the wound with warm saline. Next, the surgeon explores the injury. They check for hidden damage to nerves or tendons, and they secure complete hemostasis. When it is time to close the skin, it must be completely relaxed. If tissue is missing, they might use a skin graft, or they might move a flap of healthy tissue. Finally, they might use advanced adjunct therapies. For example, a negative pressure vacuum can gently pull the wound together and promote healthy granulation. However, this vacuum is strictly avoided if any major blood vessels are exposed. A critical component of this surgical intervention is debridement. This is the essential removal of devitalized or dead tissue. Doctors have an entire arsenal of methods for this. They can surgically cut away dead tissue until healthy bleeding appears. They can mechanically wash it away. They can use special autolytic dressings. These dressings allow the body's own enzymes to dissolve the necrosis. They can apply enzymatic ointments to break it down. They can even use biological helpers. Medical-grade larvae or maggots are sometimes applied. They are incredibly effective because they safely consume only the dead tissue.
They leave the healthy cells completely untouched.
During all of this careful repair, there is a hidden systemic threat we must address. That threat is tetanus. Tetanus is a highly dangerous bacterial infection. It can absolutely be fatal if it is ignored. Therefore, concurrent with closure and debridement, every single clinical protocol must meticulously assess tetanus risk. We stratify the injury into one of three distinct categories. First, we have clean wounds. These are minor injuries. They are less than 6 hours old, non-penetrating, and show very little tissue damage. Next, we have tetanus-prone wounds. These carry a very real danger. They include deep punctures, animal bites, or compound fractures where a bone breaks through the skin. Finally, high-risk wounds are the most severe category. These involve heavy soil or manure contamination. They might involve extensive devitalized tissue, or there might have been a significant delay before the patient reached the hospital. The final clinical step is to cross-reference this wound categorization with the patient's immunization history. If a patient is fully vaccinated within the last 10 years, they are generally safe. However, if their last vaccine was over 10 years ago, a dangerous wound requires an immediate vaccine dose. If the history is completely unknown, doctors simply take no chances. They immediately administer the vaccine. For those high-risk injuries we just discussed, they also prescribe human tetanus immunoglobulin.